NCD civil society is coming together in Kigali, Rwanda to exchange knowledge, share good practice, and strengthen capacity to advocate for prevention and control of NCDs. The forum will provide the platform to strategize, coordinate, and unite ahead of the UN high-level meeting on NCDs in 2025 to ensure it brings about a meaningful change for people living with NCDs. The forum is possible thanks to our strategic partnerships and will be convened together with Rwanda NCD Alliance in collaboration with the Rwanda Ministry of Health and Rwanda Biomedical Center. Thanks to our supporters who have contributed to making the Global NCD Alliance Forum a reality.
Well, good morning, everyone. I cannot believe this is the closing day, the last day of the forum. It's been packed. It's been so full of exciting sessions and points. So I'm really glad that you're here for this important session, which is all about communities and people with lived experience and making sure that they are at the table in the run-up to the high-level meeting. We've been talking about that meeting a lot over the last few days. The first one was held in 2011 on NCDs, and at that time there was little involvement with communities and people with a lived experience, and particularly with regards to policy decisions. And I'm glad to say that we've seen a lot of progress since then. We are starting to see people with real experience of NCDs, as I say, having seats at the table. Since 2020, there's been significant change on meaningful involvement, thanks to all of you guys in the room. And leaders are finally realizing that engaging with people with lived experience and communities is vital in building trust within the wider communities to making policies that are effective and that are accepted. So this plenary session is focusing on communities and strengthening them to drive change in the NCD response. We'll discuss good practice and opportunities for governments to unlock the value of communities, civil society, and people living with NCDs, promoting the involvement in decision-making. That's really important, decision-making, making sure that we've got the support, they've got the support to enable sustained participation. We'll talk about the newer opportunities with the WHO's framework on meaningful engagement and the 2024 resolution on social participation, which formalises this joint decision-making. Again, we want you to be involved. Please do tweet, so use social media using those hashtags ActOnNCDs, NCDAF 2025. So without further ado, I want to introduce my panel. I'm really delighted to introduce Florence Ariako Anam. Please come to the stage, Florence. She's co-executive director of GNP+, which is the global network of people living with HIV from Kenya. So welcome to you. And we also have Edith Mukantwari, who is a lived experience advocate. Edith has type 1 diabetes. She's a Voices for Pen Plus advocate. She's an NCD diarist, an executive director of Africa Diabetes Alliance from Uganda. How do you fit that all in, Edith? That's a lot. We also have Dr. Ravi Ram, who's a health systems researcher. He's executive director at the Madeira Institute in Nairobi and co-chair of the WHO Civil Society Commission, which was set up 2 years ago. We have Ms. Radhika Shrivastava, who is Senior Director of Free Day, which is the secretariat for the Healthy India Alliance, and she's a governing board member of that organisation, so welcome to you. And we have Dr. Joseph Kibachio, who's Medical Advisor for NCDs and Mental Health, WHO, in South Africa, formerly Head of NCDs in Kenya for the Kenyan government, so welcome, Dr. Joseph. So we'll be hearing from each person in turn, and then we'll have a short discussion before we close. So we've got a lot to cover in a short space of time. So I want to start with Florence. Florence, obviously you've come from the HIV community. We want to learn from grassroots advocates about how communities and people with lived experience can make a difference. So I wondered if you could start by telling us about the impact of community engagement and rights-based approaches in improving care and accelerating the HIV response. Obviously, we want to know how the NCD community can learn from that. How did you do it?
Absolutely, and I want to start by saying I'm honored to be here. Let Communities Lead was the UNAIDS 2023 theme, with a whole report that explains our investment in community engagement, in people living with HIV's lived experience, shaping policy, financing, and pretty much all the success that has been realized in the HIV response to date. I think that is the biggest impact you could ever imagine coming out of work that really started off with people coming together to just talk about fearing to die, which is where we came from. The foundation of the global AIDS movement lies in mobilization, which really started since 1983 and bringing people living with HIV together and those affected by HIV to advocate to an end to AIDS deaths and to smash stigma, which was the reason why many of us were dying. We are known since then for our powerful voice and presence and the ability to mobilize, influencing global policy, financing, and action. I think the HIV response has always been ambitious. We ambitiously worked together with governments and aimed to put 15 million people on treatment by 2015. We are currently ambitious to get viral suppression across the population by 2030. And a lot of progress has been made. HIV is one of the only indicators in the current strategic development goals that are making great progress. But one of the things I want to share with you as I finalize is the community campaign called U equals U, undetectable equals untransmittable, started really from communities and grassroots, understanding that if we are on treatment and we are virally suppressed and have an undetectable viral load, we cannot pass this virus to someone. In the last 5 years, community have been engaging with different actors, and currently, this science has been proved by various global leaders, including WHO, with their Stay Zero policy brief, CDC, IAS, and the Lancet, and currently adopted by many governments. I heard Mike Rubio last week say he believes and he understands that if someone is on treatment, they won't pass the virus, and they would still, as the government of the US, want to invest in seeing that happen. It took a lot of work to get there.
You hear me? Florence, I want to go back to what you said right at the beginning. Let people lead. How do you persuade people, lived experience experts, and in the community to lead? It may be a big step and maybe a big ask. That may be something they have no experience of.
I think it's ownership. It's ownership that has to be built over time. But I want to say that a lot of investment has also gone into building movements and systems and networks. Because of co-funding, it's been possible to walk into rooms somewhat in an equal playing field. Because if you also walk in unsupported to a meeting or not wanting to appease the hand that bites you, it's possible for you to also speak your truth and speak from experience. But the most powerful thing has been data, community-led research and data that aims to package our experiences, our stories of pain, vulnerability, and shame into information that can be useful for changing policy, for motivating financing, and pushing hard, sometimes with discussion, sometimes diplomatically, where it was impossible legally, to ensure that our space is secured at the table.
Sure. And you've touched on this a bit, but just can you add in terms of, I've talked about the high-level meeting, you've talked about engaging with senior leaders. How can you get secure political commitment at these types of meetings and on multilateral processes and at the national level? How did you do that?
I think, and I want to say this because I came from the country community level interventions back then when I started. A lot of it has started from taking ourselves there even if there was no space for us, and pushing and asking. And I think for the HIV movement, because many of us just did not want to die, we were motivated to be there. We did not care where the meeting went. So there's that personal conviction that is really important. But I think over time we have institutionalized community innovations. So sitting in support groups talking about stigma, but moving that into what we called PLHIV Stigma Index, a model of research that to date is probably one of the best innovations we have, that started to document stigma and discrimination and use that to ask governments to address stigma with the laws and with the policies that they can. And now is part of the indicators within the HLM political declaration on HIV, and UNAIDS has to report on that every year. So institutionalizing innovation is also one key way of making sure that you're constantly and your seat is secured at the table.
I mean, finally, we're really pleased that you're here to talk about this, and I wondered, what are the opportunities do you think for the NCD community and the HIV broader, global health society and community to work together to further this, social participation and this community engagement?
I think there are many, many opportunities, Jackie, and maybe I will talk about more later. But for now, I think we need to understand that because of the incredible progress in science, HIV has shifted significantly in the last decade. People living with HIV can live long now, and many of us are getting to our 50s. The UNAIDS reported that in 2023, there are 9 million people living with HIV aged 50 and above. That number is projected to go to 14 million by 2030. 4.6 million of those live in the Eastern and Southern Africa, about 1.5 are in West and Central Africa. So for us now, integrating HIV and NCDs have become real. And this is an opportunity for us to collaborate more and work together within the systems and the structures that you have and we have to keep moving forward towards responsive service delivery, both for HIV and NCDs.
Thank you, Florence. That's excellent. We'll come back to you later, but I want to move on to people with NCDs in the community. Edith, I hope you don't mind me revealing a little bit about you. I think you were diagnosed with type 1 diabetes at the age of 16, and as we know, type 1 is a very, very serious condition, and obviously Florence has just said one of the motivations was, people were dying, and this is a condition which is, if not treated, is, I was looking at some data yesterday, children in sub-Saharan Africa are diagnosed with type 1 diabetes. It's a high death rate in the first year of the diagnosis. So I wondered if you could share a little bit about your story and how you leverage your lived experience as an advocate, not only in Uganda, but in the region widely.
Thank you, Jackie. I'm happy to be here. Thank you so much for the opportunity. I think for me, what really stands out for me is that my story is an exception, and we need more exceptions. And basically, I was diagnosed with type 1 diabetes at 16, like you've said, but I had undiagnosed celiac disease for over 30 years, and that further complicated type 1 diabetes for me. So when I came into advocacy, really like Florence said, with a fear of dying. And I came into it with a lot of anger. I came into it with a lot of frustration and with a lot of fear. But I was desperate too. And the desperation pushed me to push the boundaries. So in a place where there was not much advocacy going on, not much patient engagement, not many opportunities to reach out, I had to take the first step. I had to reach out to people, and I didn't know many. So it really took a lot of networking. But thankfully, doors were opened,
Can I just ask, so 16 when you were diagnosed, you were angry. How soon was it that you made these decisions and started becoming an advocate as you've described?
That's a good question. So I was diagnosed in 2016, 2006, and I started advocacy in 2018. That was 12 years later.
Yeah.
And before then, really, anytime I needed information was really reaching out to the medical doctor to ask questions, and would get answers, but rarely did the answers prove effective. So we had to take our own initiative to find the answers that would work for us. And through that, we've been able to really build on a lot of resources available, information that's available, and we want to actually start really developing those resources that we can share with the wider community. But I also know that the fact that doors were open and I was able to meaningfully engage, really tell my story, really get the kind of information I needed, has allowed me to reach out to the broader community as well and bring in more advocates, and that has really helped. And also, working with other advocates actually encourages advocates to come up. It gives us hope. So I think for me, seeing the difference between when I had no advocacy, no power at all, to when I started stepping up and started to get some power, started to get some information, started to get into rooms that most people were not even aware existed. That really shared an example with so many people in the wider communities to step up themselves.
Sure.
Yeah.
And just briefly, can you maybe give us an example in the wider region of a project or an involvement where there is meaningful engagement?
Yeah.
I don't know, we might come on later to the WHO framework on meaningful engagement and how that can be used to make things a reality, but just if you want to briefly give me some good practice that we can all look at and take away.
Yeah, that's an exciting question. In 2020, I attended my very first opportunity to attend the NCD Alliance Forum in Sharjah. And during that meeting, there was formed an organization called the Africa NCDs Network. And initially I thought, it's not going anywhere. But fortunately, with the resilience of the leadership, we've seen them move from we decided this at a round table of about maybe 20 people. And now it's a vibrant organization. And they've put in so much energy and resources into developing meaningful engagement policies, meaningful engagement, sort of like even shared stories, publishing stories. They've really looked into providing guidance for the member organizations about how to do meaningful engagement. And I think that because they are also the convening leadership, that means that these best practices that they're developing can actually be used and leveraged by the member organizations as well for regional and national improvements, regional and national achievements as well in meaningful engagement. So I really would love to applaud them and give them their flowers.
Great. Okay. Thank you very much indeed, Florence. Edith, we'll come back to you again in a little bit. I want to come on to Ravi. So, Ravi, I've been told that you're a civil society engagement expert, right? You're a member of the WHO Civil Society Commission. And I mentioned about the WHO resolution on social participation, considered a landmark commitment for governments to implement this social participation in decision making. So what do you think are the implications for the NCD community? What are the good practices in this area?
Sure. Good. First, I'll just give a bit of background about the social participation resolution. It was passed by all WHO member states just last May at the World Health Assembly. And what it does is it's a means of setting a new norm for how governments and civil society work together. There are 8 principles there, and I won't go through them all, but many of them are familiar to us. Inclusive participation, equity, accountability. These are things that we already practice, and we're trying to get it to government. So that's the landmark part, that governments actually accepted it. So it does call on governments to create an enabling environment for civil society and social participation in health governance, planning, and budgeting. Importantly, it says specifically that one-off consultations are not social participation. So let's not settle for the bottom line, for the tiny little bit. Let's aim higher, because that's what this social participation resolution does. It sets a new norm that we have to push governments to accept, because there are challenges. But specific to us in the NCD community, we're well placed, better in many ways than other health activists, to take on the social participation resolution. We already have meaningful involvement of people living with NCDs as part of our DNA. So let's build on that. Let's push it further. I think also, let's also address the challenges. And as much as governments have signed on to this, they may not have the processes in place or the resources to really make social participation happen. That's our first step. And we also have to acknowledge that they may have signed on, but they may not really want it. It was just too hard to oppose. A second challenge is within us in civil society, because we have our own power dynamics. And as much as this is a great tool at the national level, it's the international, national, well-funded, advocacy-oriented NGOs that can dominate and leave behind our brothers and sisters working in community-based organizations or people living with NCDs because they're not attached to these larger organizations. So let's make sure that we are inclusive ourselves, even as we push governments. And then the second real challenge I'll bring out is that it's not just these structural and political issues, it's the narrative that we have also bought into. There's two lies embedded in our narrative, I believe. One is a scientific one, and we've heard it even in the forum in the past few days, the so-called epidemiological transition. Whereas societies move away from infectious diseases, naturally we're going to become susceptible to non-communicable diseases. I'd like to actually point out that it's not just that we're living longer and therefore older people are more susceptible to diabetes, heart conditions, et cetera, or cancers. Let's applaud the young people here who are standing up and saying, I have an NCD. And they are living proof that this epidemiological transition is not because we're living older, it's affecting everybody. And the second thing is that age-specific morbidities and mortalities don't line up with what we expect. As we reduce infectious disease burden, we're seeing not just the diagnosis of more NCDs, but the incidence of more NCDs. And we need to address that, which gets to the second point, not a scientific one, but a political one. And the lie is that these are lifestyle diseases because it's an individual burden. Somebody did something wrong and they made their choice, now they're living with this disease. Our individual choices are shaped and constrained by policy decisions and fiscal policy by our governments. And those create the environment where we can have the economic conditions that promote NCDs, that drive the epidemic. And my favorite example, I use this all the time back in Kenya, is that we subsidize sugar production rather than tax the calorie burden that we're imposing on our population. So when a migrant worker comes from upcountry to Nairobi, they need to get some food. The cheapest option is actually fried sweet food. They are making a rational choice based on what's around them, and they're making themselves susceptible. It's because of policy.
Thanks, Ravi. I think we had sessions yesterday talking about that very same point. But I want to bring it back to communities and civil society and lived experience. But you mentioned the participation resolution. You're not sure how it's going to play out in terms of whether it will actually be effective, or people have just signed up to it because they had to. But let's moving forward to the high-level meeting. How can we make sure that actually social participation happens in practice? How can the NCD community leverage that meeting to take forward social participation and build on it?
Sure. I'll say first, the social participation resolution didn't come out of a vacuum. It built on progress, and we saw a lot. Thailand is the global example. I learned in this forum that Malaysia is not too different from Thailand. Ghana has stood out because of very strong civil society activism and advocacy around NCDs and other health issues, and also recognize sometimes at the municipal level. Porto Alegre in Brazil, as well as the city of Santiago in Chile, they've both been pioneers in bringing social participation in making healthier societies, and even the government of Ireland. So it's not a standalone piece. Looking toward the HLM, what do we really want to see happen? First, let's make sure that we can bring social participation at the national level and even reinforce it at the global level. And secondly, what do we want to see in the HLM? Let's use this social participation to change the narrative. Because if we remain trapped by a narrative that says, I as an individual, I'm responsible for my disease, we're letting so much of the actors, the commercial determinants of health, off the hook. And I think that will be key. That is very important for the HLM.
Thank you, Ravi. That's really helpful. So great to hear from these experiences in Africa and the research that we've been doing. But I want to move to India now. Radhika, so you are part of the Healthy India Alliance. It's one of 60 national alliances that are here at the forum. How have you seen the recognition and role of NCD, civil society, and people living with NCDs changing in the last, say, 5 years in India?
Thank you, Jackie, for that question. We feel that in the last 5 years, rapid strides have been made towards meaningful engagement of civil society as well as people living with NCDs at the global, regional, national, local, and even hyper local levels. CSOs are widely recognized as the link between communities, people living with NCDs, the health system, policymakers, and the government. It cannot be denied in today's world that any response in any geography on meaningful living on NCDs will be deficient and incomplete if the voices of lived experience champions and CSOs are not embedded into it. And so we are very proud of the journey in India, and we feel that yes, meaningful involvement is not a destination, but an ongoing process. We have a very supportive government who is now open to listening to the views and voices of lived experience champions as well as CSOs. And over the last few years, there has been a clear shift in the narrative of people living with NCDs in our country. And the major milestone has been the inclusion of meaningful involvement of lived experience champions in India's national program for prevention and control of NCDs.
Radhika, what was the trigger for that? Why was the government, listening? What happened to make, was it your advocacy that led to that, or?
Absolutely. I think our advocacy and advocacy of several civil society partners like us who have day in and day out made sure that every document, every comment, every resource, every platform that we have had, we have made sure that meaningful engagement is included and highlighted. So much so that, when we are now speaking to our government representatives or key decision makers, we absolutely make it a point to drive the agenda of meaningful engagement and involvement into their minds, because it is not something that just has to be on paper. We have to walk the talk and utilize every opportunity, no matter how small or how big, to make sure that that agenda is up and center and visible. And at some point in time, that is where we would see it being translated into policy action.
Yeah, of course, it's great to hear about that advocacy win, and then it's included in that strategy. But we've heard a lot about at the forum, policies success, but implementation deficit. So how do we make sure that, okay, it's in the strategy, it's supposed to be there, that actually it really happens?
Yes, that's an excellent question, and something that we've been discussing a lot at the forum, and even been discussing in our alliance as well. And so we feel that meaningful engagement is a multi-stakeholder process. People need to embrace and adopt and act on meaningful engagement. So meaningful engagement is not the agenda just of people with lived experience, not just of civil society. It has to be a priority for governments, for policymakers, and more importantly, also for the health system. So the health system needs to be geared to embrace meaningful engagement, and so it is not just a one-sided approach. It is a multidimensional approach. There also need to be models, and that is something that Florence spoke about, is that it is, in a way, while it takes time to get meaningful engagement on a policy document, it is even more difficult to then answer the question that policymakers now pose to us: how do we do this? Right? And so it's very important for us. For example, in India, we now have the Indian Council of Medical Research, which is the apex research body of the government of India, investing resources and technical support in identifying models of community engagement and meaningful engagement that work, and hoping that these outcomes, which are grounded in evidence, will be used to inform the program and to scale it up at the national level.
I think there is hope in what you say, in the sense that the government is asking you, how do we do it?
Yeah.
You've got that seat at the table. You've got to have a plan to be able to answer it. Right. But the fact that they're asking you means that I think there's real proper engagement there. So that's great. Thank you very much indeed for telling us about the experience in India. But let me move now to South Africa. So, Dr. Joseph, as I said before, former NCD director for the government of Kenya, current advisor for the WHO in South Africa. I wonder, what's your experience of working with civil society and people living with NCDs in NCD prevention and treatment? Is this integral, and can you give me any examples of what you found?
Sure. Thank you, Jackie. It's been an interesting journey, and I think the best way for me to reflect this is to just look at how the people with lived experience have evolved over the time that I've been. I started with the NCD space just post the MDG era, where we were just discussing the SDGs. And at that time, I remember the face of the person with lived experience was just an expert patient prepared by the clinicians to say exactly what they want to say. Most of the associations that time were formed by doctors. I remember in my country, there's a physician who sees diabetes patients, so he forms a diabetes association. So life revolves around the physician. And then now we had the expert patients. Then the NCD Alliance came, and very well structured. We've come a long way, as Radhika said. Then we reached a point where we have now very structured advocates, the likes of Mukantwiri here, Newton, Chris Agbega, young people, Leah Kilenga, who I look at in a very different way. That my sister here is probably in her 30s, in her 40s. She has 40, 50 years to live. You want more years in your life, but not only that, you want more life in those years. It is personal. If the government wants to do something, I must intervene because I have all these years and I want quality in them. And also, they participate in platforms to make change. Then now we are moving over to the next phase where, because of the multi-morbidity, I'm happy my sister from Kenya is from the HIV Civil Society. There is no one person who just has one disease, especially in sub-Saharan Africa. The same person who has TB is the same one who has diabetes, is the same one who has HIV, is the same one who also is struggling with a mental health issue. So when diseases come together, we must come together. So that's my experience of how it has changed. But let me give two examples, one in Kenya and one in South Africa.
And before you do that,
yes,
your passion is fantastic. I'm aware that there's some translators for people who are not speaking English, so maybe a little slower would be great. Because we all want to hear these great examples.
Perfect.
Go ahead.
Sometimes passion consumes us here, Jackie. So let me give the example in Kenya, and I'll give an example of Leah Kilenga. I don't know if she's here. Very early on, they were calling themselves the sickle cell champions, warriors actually. No space around the table. And I remember one time we were launching the NCD strategic plan in Kenya. On the program, there can only be a few people. Leah is not one of them. Sickle cell is not one of the diseases we are considering today. Diabetes, hypertension, cancer, yes. And the minister is coming. So they say, okay, we can't appear on the program, but allow us to just use one of the walls in the hall. So we say, okay, go ahead. So they start beaming pictures of young people on that wall without anything being said, over and over throughout the whole process. And later in the evening, the minister asked me, who are those young people who were being put on the wall? And right there, a small disease that didn't have a voice now disturbed the minister, and the story started from there. I go to South Africa and I meet a totally different brood of advocates. South Africa is a different terrain. We have seen how the HIV people took life in their own hands and they forced governments to do things. So I meet Vicky, who we will be eulogizing very soon. Very interesting space where, as we sit, Vicky has sued the government for not involving people with NCDs in the development of policy. At the same time, in the evening, we sit together with the same person who has sued us. We don't burn bridges. Very interesting civil society who, we call it the rodent maneuver, that you see when a rat is eating food morsels from your fingers, it blows as it eats so that you don't wake up. So it's able to bite, but at the same time, makes sure that it doesn't burn that bridge. And that is a face of advocacy that we want to co-create. Civil society, especially, is not an enemy of government. Sometimes we have to speak hard to government, but sometimes we have to sit down and talk with government. So that's the transition I've seen, the maturity of the NCD civil society. And thanks to the NCD Alliance, and also to the mentorship of the people who went ahead of us. I see here the likes of Zipporah Ali, Dr. Eva Jenga, who have mentored the young generation of advocates and used the platform to give them a seat around the table.
Thank you for that. But I want to come on to bring it back to the high-level meeting. Obviously, you've got experience at a very high level. You know who will be at that meeting and you know the type of personalities and how they'll be discussing this. So what do you want to see come out of the agenda, you know, in terms of priorities there that the ministers will be talking about and discussing ahead of the declaration? What do you want from that?
Let me give you a context of these two cities, Geneva and New York. Geneva, we meet in May, it's the World Health Assembly, it's a ministerial level. In Geneva, we do declarations. When a disease moves from Geneva and crosses the Atlantic to New York, to the United General Assembly, it's no longer a disease. It's a social developmental issue that requires the whole of government. It's at presidential level. And a lot of things are released to control it because it's no longer just a disease. That has happened to a bunch of diseases. That's HIV, TB, UHC, and NCD has been lucky to be amongst that. But something has happened with the NCDs. It has not only had 1, 2, 3, it's going to have 4. No other disease has had that. But yet, there's still no movement. HIV just had one meeting in New York, and in New York, we don't do resolves anymore. We declare in New York. The president declares. It's a declaration now. But somehow, the NCD space, we don't see it coming out the way it came for HIV. So what do I want to see this time? I want to see less of Geneva language in that resolution and more of New York language. Let me explain what I mean by that. When a disease is articulated at the United Nations General Assembly, it is no longer a health sector issue, it's a multi-sectoral issue. The Ministry of Education has to tell us what they're doing about NCDs, industry, agriculture, all those, because that's the way NCD is structured. The next thing is that resources are availed to, because it's no longer a disease entity, it's a social developmental issue that needs a whole of government approach. And then we need to have measurable outcomes. When I read the last declaration yesterday, I was surprised that we talk of make more people aware, involve civil society more. How do you measure that? So we want to say, in the health budget, put 5% for community-led organizations to do awareness. Now we can measure that. So I want the civil society to insist on a role in that resolution, and not only a role, but a measurable role.
That's a lovely, tangible ask there, so thank you very much indeed for that. Now, look, we've got a few minutes. I'd like to, to have a little discussion amongst ourselves because there's been so many points that everyone's raised. I'm wondering, we've been talking about why it's so important to involve people with lived experience and communities, but what are some challenges that have to be overcome to actually make this effective? I'll ask Florence, first of all, if your experience, and then I want to talk to others about, how challenges have been overcome, what the main barriers are.
I think I'll talk about challenges broadly, but then challenges to the HLM regarding what my brother from Kenya just said. I think one is not many civil societies are adequately resourced to translate global wins into actual country actions. So then things are done and made and they stay in Geneva. Many people at country level don't even know that these policies exist, that their governments made these commitments. And I think the push from organizations like GNP Plus is how we are interfacing this advocacy loop that is local for global. And it doesn't stop at the global, we move it down. But we have to constantly jostle for space, jostle for funding, and it requires consistency and intentional education and learning the structures from which you're engaging. Like he rightfully says, WHO is not the same as the UNGA. It's not even the same as, even PEPFAR and Global Fund are different. And they give you big documents, lots of words, and it takes time to actually understand the structure from which you can participate so you can ask. In the PEPFAR space, we had to write our own people's corps. We used to call them that because we had to go and learn and understand the language that motivates the US to put money to the things that we need. Because they say we don't understand. We used to have those broad awareness things, but now we don't have those. We really write people's corps with data, with actual costs, and that has been helpful. The second and most important, I think, is the narrative. What's the narrative, and is it able to drive global solidarity? Global solidarity is waning because there are so many things right now wrong with the world and we can't keep up. But I think we need to find some bold narrative around why this is important to take cognizance of. Non-communicable diseases don't affect one individual. In fact, I think the worry for many of us in the HIV space is how we have struggled to live this long, but we do realize that it will be just one disease that will get us off, and it's something we can manage and control, but we didn't even have the space and awareness for that. Thanks.
I think, Ravi, did you want to come in? But I think I want to pose to the panel, is it a difficulty and a barrier that, as you say, many people with NCDs have multiple NCDs? It make it a more difficult narrative to tell, and that's why, governments, it's harder for them to hear. But Ravi, you wanted to respond to what Florence was saying, I think.
Yeah, I'd like to build on my brother Tamatio has mentioned also, and also Florence. There's a lot we can learn from our predecessors, and especially the HIV/AIDS movement. They made a social movement, and they simplified their narrative. There are so many complexities. It was an unknown virus. It had a new etiology. Scientists didn't know what to do, and people were dying. But they moved quickly. Even as their brothers and sisters were dying, they mobilized, and they made the point that we deserve action from our governments. And I think that was crystallizing. They didn't just solve their own disease-specific problem. They changed societies as they went. And I think that's a huge lesson for us. A key point to remember is they also learned from their predecessors. It's the disability community that said, nothing about us without us. And the HIV movement said, anything about us without us is against us. Let's take that forward.
Thanks, Ravi. Who wants to come in?
I
think Edith, yes.
I'd like to build up on all the amazing points that just came up and just say from the WHO, building from global to local they've been trying to ease that by creating a framework for meaningful engagement. And this is something that has, right now, the framework contains 5 principles and 6 enablers that would be effective in properly encompassing what meaningful engagement means. And that can help us as advocates do that. And from that, we've moved on to create 4 key messages for the UN General Assembly, which entails 12 different asks. And these are tools that we can use to ease the messages at national level and regional level. And I believe that civil society can really be a big player in this, because basically what it entails, tries to do, the framework tries to build power on the ground. It tries to also shift power and balance power out. Right now, power does not lie in the hands of the people, and we're trying to bring some power into the hands of the people. And balancing power or shifting power doesn't mean anyone else's power reduces. It just means that someone else builds more power. So that's just to tell the people who currently hold the power that it's not anything against your power. No, it is just to build collective power for each and every one of us, to make sure that when we make the asks that we want to make, we have the power behind us to get those things moving. And I just want to say that even as advocates, I'd love to encourage us to move away from listlessness, to move away from passivity, and move seriously into being very active, move seriously into pushing boundaries, move seriously into talking to each other, creating power with each other, because again, building power vertically is not helping anybody. We need to build power horizontally with one another. And I'm really, really happy to see that these conversations are happening. And thank you to all your amazing points.
Thank you. Now, you haven't got off the hook yet. We've got another few minutes yet. I want to, Radhika, do you want to add on to and build on to any of the points that have been made?
Thank you. So I think that meaningful involvement also needs to follow an equity-based approach. When we say no one should be left behind, I think the current lived experience champions who have the platform to advocate should make sure that irrespective of age, gender, socioeconomic status, everyone in their communities should be involved. And here I'd like to also bring attention to young people living with NCDs. And so very happy to see the representation of the type 1 diabetes community. And I think there is also a need to focus on other NCDs which are of childhood onset. Because there cannot be, to quote UNICEF, there cannot be NCD prevention and control without the middle C, that is children being involved. And I'd like to just sneak in an opportunity here to invite all of you to the UNICEF satellite session where our youth are going to release the Kigali youth statement right after the plenary.
That's great, thank you. Now, Joseph, you've already talked about what you want at the high-level meeting, so I'm not going to ask you this question quite now. I'm going to ask each of my panels, though, in 30 seconds, and I really mean 30 seconds because we are running out of time. High-level meeting, Florence, what would your top key message for governments coming from communities and lived experience perspective be? Just in 30 seconds.
I'm asking for the biggest currency, political goodwill and leadership, because that's what will give us the fiscal space to actually do the interventions we need to do.
Thank you very much indeed. Edith, what about you?
For me, it is to say we are only stronger together, only. And we need to be strong even in the multi-sectoral approach. So even as advocates, we should spread out into the multi-sectoral approach.
Thank you, Edith. Ravi?
Yes, I've spoken about changing the narrative, and there's one more piece we need to consider. WHO is under attack, and that means science is under attack. Let's stand up for WHO. We have some friends here in this forum. We have many more around the world. WHO needs us right now.
Thank you, Ravi. Radhika, what's your key point?
So let us all adopt a people and a partner-centric approach and not just a patient-centric approach.
That was less than 30 seconds. You called me out there. Joseph, you talked about the high-level meeting. So I think rather more broadly, what's the one takeaway message that you will want this audience to know about involving communities and lived experience at the highest level with proper, meaningful engagement?
I would say meaningful engagement, of course, is a right, and participation is a civic duty. Each of us here have a member of parliament. One of the persons in one of the plenaries the other day said that we are lacking some persons here from parliament. The Nigerians say he who holds the arm and the knife is the one who counts at the end of the day. Those people in the parliament, I take an example of TB. They have a TB parliamentary caucus. Those parliamentarians don't have TB, but whenever TB is mentioned in those houses, they stand up and ask very difficult questions. 30% of our parliamentarians, or even 40%, are having an NCD. Yet when NCDs are mentioned in those houses, they don't speak. Why? Because we have not packaged them. It's our time to package them so that they are a mouthpiece in those houses. When resources are being apportioned, let them be our voices where we cannot be able to enter. So mine is to say that, and then finally to say, what gets counts at the end of the day. Let's not just look for qualitative statements in those resolutions. Let's look for things which we can count, and another 5 years later, when you go back to New York, we can look back and say, we said we'll do 300, we have done 2, or we have surpassed ourselves. So let's look for things that can be counted, because they count.
Thank you very much indeed, Joseph. Well, look, Yeah, I mean, we'll give them a massive clap at the end because it's been an absolutely amazing discussion, and I'm so pleased that you've all been here. I would add to what you've just said, Joseph, get that message across. Obviously, I'm a journalist, and I say, you know, not just talk to your MPs, write letters to newspapers, appear on the radio, give interviews, and get that message across. And I hope that I'll be doing so in the Lancet next week, all things hopefully considered. So let me just sum up what we've been talking about. I think what we all know is that this is a unique opportunity with this high-level meeting. Yes, you've made the point, this is the fourth compared to HIV, which only had one, but there's momentum here, isn't there? And I think you know, we need them to commit to including the voices of people with lived experience and communities, and make sure they're not just heard, but there's effective participation. Make sure people have got a seat at the table and act. It's not just a tick box approach, it's meaningful engagement. And we can see here and here what strong civil society there is in NCDs, and it's growing, but it can't work in a silo. And we've talked about HIV and the collaboration that we've seen and the shared agenda. So that's really, I think, a force for good, and that's wonderful moving forward. So I think let's ensure that this coordinated advocacy working together with broader global health continues. And I'm sure with people like Florence, with Edith and the others, we can see this happening. It will happen. But on that note, we all want to pay tribute to two remarkable NCD advocates who we actually lost last year. And I want to hand over to Dr. Joseph to introduce this, so please do go ahead.
So good morning once more. I have the honor of leading us in reflecting on two warriors, two champions of the NCD movement that we lost last year. Last year was a difficult year for us. Two of them, one from South Africa and one from my country, Kenya. Dr. Vicky Pickney Atkinson, if you have seen the NCD Alliance documentations and activities, you definitely must know this grand old lady who was a comrade and a friend. With over 50 years of diverse experience in healthcare, she dedicated much of her life promoting equitable access to NCD prevention and control and treatment access. She was the director of the South Africa NCD Alliance and also supported us as South Africa to develop the NCD strategic plan. Her efforts were pivotal in all manner of access for NCDs. She herself lived with over 20 NCD conditions throughout her years. She talked truth to power very boldly, yet not burning bridges, as I said earlier. She asked difficult questions that we all must ask. She harnessed strategic partnerships and alliances for the greater good. She used the public system throughout her life and wanted to reform it from within. She was a true champion. I will end for her tribute with a quote that she told me one time when she was not feeling very well. She said, "Joseph, we are not trying to live forever. We all will die. But what we are trying is to build something that will live forever." And as I look in the NCD Alliance today as we meet, we are basking in the glory of that living forever. She liked to say that engagement is a right and participation is a civic duty. Indeed, an NCD advocate by excellence. May Vicky rest in peace. The next one is Charity Muturi. Charity Muturi was in the mental health space. Charity was a friend, a great one at that. I knew her personally. And an ordinary girl, fighter, and a mental health advocate, all rolled in one. Charity died of suicide. It's a difficult one. It's a cause which she had advocated passionately, including petitioning for the decriminalization of suicide in Kenya. She was pivotal to the work of the NCD Alliance. She was supposed to be a moderator of one of these panels. She was key in the NCD Alliance in Kenya and the East African region. Charity pushed for the global charter for meaningful involvement and was advocated towards the WHO framework, which we now have. Charity was such an inspiration. She was an amazing spokesperson with great charisma. She lived her life advocating for the change of the law to help people struggling with suicide ideation to seek medical help and to get it instead of being dragged through the legal and criminal justice system. Together with the Kenya National Commission of Human Rights and the Kenya Psychiatric Association, they sought a declaration that the section 226 of the Kenyan laws criminalizing attempted suicide is unconstitutional. And indeed, posthumously, just last month, the High Court of Kenya declared that section is unconstitutional, and attempted suicide has been decriminalized in Kenya. It's sad that she paid the ultimate price. We have a video that we'll show to pay tribute to this too. If you can show the video, thank you.
Don't speak for us, let us speak for ourselves.
We've been able to meet and encourage each other, but also to support each other, where we would not be able to get support from anywhere else.
The main killer of South Africans and causer of illnesses and deaths are non-communicable diseases.
We are the ones who see where our systems succeed and where they fail us. And when they succeed, we thrive. When they fail us, we pay with our lives.
If you may, and those who are able to, I would kindly ask you that we stand up for just 30 seconds to remember these two great souls. Thank you very much. May they rest in peace.